right. Well, first of all, my name is David Armstrong, and I'm the director of the Health Workforce Technical Assistance Center. And welcome to our event today. It is entitled Bridging the Gap: Community Health Centers and Geographic Inequities in Medicaid Healthcare Access. And in case you don't know about us, we are HWTAC, the Health Workforce Technical Assistance Center. And we are located at the Center for Health Workforce Studies at the College of Integrated Health Sciences at the University of Albany, State University of New York. And I said of, didn't I? It's University at Albany. With that said, our mission is to provide technical assistance to states and organizations engaged in health workforce planning. And part of that assistance involves this webinar series in which we try to bring to you the most current research within the health workforce sphere. So if you haven't already, go ahead and check out our website at healthworkforceta.org. And by all means, sign up to our mailing list so you'll receive notifications about upcoming webinars as well as other events. And with that said, today we are joined by Jordan Herring, a PhD and postdoc at Stanford University School of Medicine. Jordan, welcome, and thank you for being here.
All right. Yes, thank you, David. I am, like David said, I'm Jordan. I am a postdoc right now at Stanford University School of Medicine, but I'm super excited to talk today. Title of this talk is Bridging the Gap: Community Health Centers and Geographic Inequities in Medicaid Healthcare Access. And most of this talk today is based off of a paper that was just published in JAMA Health Forum from the team that I worked with at George Washington University. Most of this was done while I was at George Washington, and it was actually part of my dissertation, but it was also funded by the HRSA Health Workforce Center at George Washington University in combination with the Fitzhugh Mullen Institute for Health Workforce Equity. And so by extension, this doesn't reflect the views of the Bureau of the Health Workforce, NCWA, HRSA, or HHS, or the United States government. But what were a central problem and question we were attempting to address in this study was that there was substantial variation there is substantial variation in access to care in Medicaid. And this has an important question for how resources should be targeted to help close what we call need gaps in accessing healthcare. The main way, or one of the main ways that this has currently been operationalized within health policy is through HPSAs, or health professional shortage areas, or other similar definitions that mostly rely on county level supply factors, things that relate to essentially the number of doctors in an area, the number of healthcare providers in an area, that really focus on just the supply side. And this paper from Justin Markowski and team at Yale was just recently published in Health Affairs that was evaluating the effectiveness of HPSAs over the past 50 years, and basically found that this approach to making these designations based off of supply factors has basically done little to nothing over the past 50 years. One of the highlights that they reported in this paper is that 73% of counties designated as HPSAs remained physician shortage areas for at least 10 years. So these designations, based off of physician supply, basically have done little to change mortality. They have done little to change the distribution of physicians in the United States. And so the idea is that we need a better way to target small scale areas based on not just supply, but based on access and need, which is sort of difficult to do, although conceptually it may be kind of straightforward. But identifying these access and needs gaps are pretty difficult to do in practice. And so this conceptual framework, this the theoretical approach that we took to try to exactly identify areas that may be in need of healthcare, really goes back to some work that was published in the late 1990s on concentrated poverty from an author named Jargowski, who wrote a book called Poverty in Place. That was really one of the first really comprehensive pieces of work talking about how American poverty, the concentration of American poverty in certain areas, not just cross-sectionally, but how over time poverty has become more increasingly concentrated in certain areas. meaning that places have become very, very important determinants of access to certain services. And this is not just specific to healthcare, but this extends to access to all kinds of institutions and services such as education and anything really that we think about as important factors to economic and social well-being. Around the same time, economist Amartya Sen published a one of his most famous pieces of work called Development is Freedom, which really stressed this idea that poverty, or how we think of as poverty, is much more than just low incomes or income-based definitions. Most of what, especially in the United States, when we determine poverty levels or the federal poverty line, that is based purely off of income. And the ideas from Sen were basically pushing this idea and arguing for the need to address to define poverty and address poverty in a multidimensional way, that someone's disadvantage in the economy or in society comes from not just income or money, but has to do with a lot of different things, that is a little bit more holistic in terms of how we identify poverty and disadvantage. And so the idea was basically combining these two central pieces from a conceptual framework to focus on this work from Jargowski that discussed the increasing concentration of poverty in certain areas, but essentially expand that definition of poverty to include this idea of multidimensional disadvantage. And of course, this idea of concentrated multidimensional disadvantage is supported by a vast literature on social determinants of health, that has produced a lot of conclusions and a lot of great evidence that there are many non-medical factors and non-income factors that affect healthcare access and healthcare outcomes. So one of our and there's two main research questions. The first research question that we had was, how does the CDC's Social Vulnerability Index explain geographic variation in Medicaid primary care use? The CDC's SVI is a multidimensional index based on area level variables. So this is the tool that we identified or used to identify the concentration of multidimensional disadvantage. The CDC, or the SVI, was developed by the CDC mainly for disaster planning and public health emergencies. The CDC developed this index to help aid emergency planners and public health officials to prioritize certain areas that would likely be more in need of public assistance or disaster recovery than other areas in a time of high need and high distress. And state and local health departments and nonprofits have used the SVI to guide community-based health promotion initiatives as well. This SVI is publicly available through the ATSDR website on geospatial research. It actually was taken down earlier this year, but it is back available with a disclaimer from the administration about some things related to gender ideology, even though that's not included in the SBI at all. But the SBI, the CDC took this approach to measuring overall vulnerability through 4 different domains. So these domains that underlie what the CDC called overall vulnerability related to socioeconomic status, household characteristics, racial and ethnic minority status, and housing and transportation type. And so within each of these domains, the CDC tracked certain census variables or demographic variables to capture socioeconomic status more broadly. So the variables that are included in this domain are the proportion of people that are below 150% of the poverty line in that area, the proportion that are unemployed, the proportion that have housing cost burden, which is defined based off of how much you pay for housing relative to the amount of income that you have, the proportion of the population without a high school diploma, and the proportion of the population without health insurance. And the next domain has to do with household characteristics, which is a little bit more focused on demographics, but it includes variables based off of the proportion of the population that is 65 and older, the proportion of the population that are children, and other factors such as those with disabilities and households that are led by single parents and people that with limited English language proficiency. And the third domain has to do with racial and ethnic minority status. This is the proportion of the population that is a racial or ethnic minority is described in this box through all these different categories. And the final domain is housing type and transportation, which relates to the proportion of structures that are multi-unit, that are mobile homes. They also quantify household crowding to get a measure of how many people are in a house per household bedroom to try to proxy for maybe economic or housing disadvantage in that type of measurement. And then also the proportion of people without a vehicle and the proportion that live in group quarters. And so I won't, for the purpose of this talk, I won't go into the detail of all this. It's calculated, but essentially what the CDC does is calculate all these different variables at a geographic level and combine them through some percentile rankings to get a score for the geographic unit, and then that scores and geographic units are sorted into different percentiles, where higher percentiles or a higher score basically means higher disadvantage or higher social vulnerability. The SPI and other social indexes have been used very widely in health services research. There's been several systematic reviews conducted on this topic, and all kinds of outcomes such as cancer screening, hospital admission, pharmacy accessibility, suicide risk. Anything that you can think of has basically been studied in general with the social vulnerability index, except for primary care use and Medicaid. And so our focus on primary care use and Medicaid is filling a research gap in this area in general, but it's also really trying to focus on access, not just on some outcomes, but trying to proxy for true access to healthcare and how that may vary geographically. And so obviously the huge limitation here is that utilization doesn't always equal access, but at least maybe it could be a good proxy. And we use a piece from Ben Summers and Renuka Tiberini that was published in JAMA Health Forum to kind of help motivate this. Ben Summers and Renuka published a commentary piece about really digging into details about how we quantify access gaps and patient access in Medicaid. And they had a paragraph in this piece that was talking about how actual patterns of healthcare use do reflect access to care. And then they mostly went on to talk about the comparing Medicaid to private insurance, but we're kind of taking this type of argument to look at variation within primary care use within Medicaid in attempts to use that as a proxy for access to care. And so our second question, which was related to kind of some of the solutions, but how do federally qualified health centers contribute to closing access gaps in socially vulnerable areas? So I'm going to use this acronym FQHCs to refer to these health centers mostly throughout this talk. I'm sure many of you are familiar with FQHCs, but for those of you that are not, their FQHCs date back to 1965 and even before that, but in 1965 was around the time when community health centers really started gaining ground and gaining traction. If you go to chcchronicles.org, which is maintained by the Geiger Gibson program at George Washington University, there's a lot of great material about tracking the development of FQHCs. But the idea is that these were supposed to be clinics that were staffed by community members for certain community members to provide healthcare in areas where healthcare was very difficult to access or very difficult to come by. And so part of the initial rollout of FQHCs was a part of the United States War on Poverty in the mid-60s. In the 1965, this is around the time where large public health programs such as Medicare and Medicaid were rolling out. But this was really the first step that the United States took as part of a government-funded direct provision of healthcare. So FQHCs are not an insurance program, but they're essentially public clinics that are directly providing healthcare in certain areas. And one of the best papers on the effectiveness of FQHCs, I think, was this paper by Martha Bailey and Andrew Goodman Bacon, who are economists, that published a paper several years ago in the American Economic Review that was looking at the mortality effects of the rollout of FQHCs in the mid 60s and found pretty large effects. And so what you're seeing in this graph is an event study that's showing the number of or the number of years since a CHC was established in a particular county, and this black line is showing basically the implementation period. And so as soon as everything to the left of this black line is showing changes in mortality rates, that essentially mortality rates were pretty constant up until the implementation of community health centers. But once community health centers were implemented, county level mortality rates began to decline pretty significantly and pretty rapidly. And they kind of came to this conclusion that a lot of these mortality gains were around this time were due to CHCs because there was a staggered rollout of CHCs. So there were empirical design concepts that they were able to exploit. But their big conclusion here was that primary care access has longer term benefits. And this is obviously not a specific conclusion to this paper, but this is something that we talk about a whole lot in broader policy discussions. But one of the points that they made that was super interesting and important as well is that even for populations with near universal health insurance, CHCs have this huge effect on providing primary care in areas where it was hard to access. So this kind of goes back to this idea that health insurance is not necessarily guaranteeing access to healthcare for certain people, that the CHCs made this additional step into providing healthcare access beyond just insurance coverage and insurance design, which had pretty large effects. So these were our two questions. How does the CHC's SVI relate to geographic variation in primary care use? And then, of course, how do FQHCs contribute to closing any kind of access gaps? So our research approach was based on the 2019 Medicaid claims from TAF or the TMSIS analytical files for 36 states. And we'll go into all the details about TAF, but TAF is basically a relatively new database of Medicaid claims for the entire country, which sounds super great, although because Medicaid is a state program, there's a lot of variation in Medicaid programs at the state level, which means there's substantial variation in the quality of the data in the TAF for Medicaid claims. So many states have to be excluded because of data quality issues, which I'm happy to talk about that later in questions. But we included 36 states in our analysis here. The SVI from the CDC originally comes from or comes at the census tract and county levels, but we only have zip codes in the TAF for patients. And so we use some data from Franchi et al., which is a group at Northwestern that did a great job of replicating the SVI and other deprivation indexes at the zip code and other geographic levels to make research a little bit easier in this area. And then we focused on beneficiaries that were less than 65 years old, not dually eligible for Medicare, and enrolled in Medicaid the entire calendar year of our period. For primary care identification, this is another area that we'd had a lot of methodological time spent on identifying primary care because this isn't necessarily straightforward in the claims, and I won't go into a whole lot of detail, but basically we identified primary care visits using a pretty innovative approach from Monica O'Reilly and team that published a paper in the Journal of General Internal Medicine that identified primary care based off clinician activity. So we did use clinician specialties, but clinician specialties were the ultimate primary care identification was a combination of like self-reported clinician specialties and in a national registry of providers and the actual types of activity that they were doing in claims. So this had to do with things like clinical concentration, the types of services they were providing, and the settings that they were providing those services in. And then we also identified FQHCs in the claims, and Yoon Hong Park and Eric Lowe, who are co-authors on the paper. This is what they spent a lot of time trying to do this. One of the huge innovations of this was that we can't necessarily identify FQHCs pretty easily in the claims because there's not just a simple variable that says this clinic is an FQHC. And so Yoon Hong Park and Eric Lowe spent a lot of time trying to perfect this. And this was done through taxonomy codes that were listed on organizational billing identifiers, matching algorithms, and then there was also a lot of manual matching. You can identify a large majority of FQHC billing identifiers based off of taxonomy codes, but it's definitely not a complete approach. And so these other things about matching algorithms and manual matching help pick up a lot of the shortfalls from limitations in identifying FQHCs in these more direct ways. So at FQHCs, we identified all emergency or evaluation and management services and counted those as primary care, as most FQHCs only or heavily focus on primary care in terms of the scope of medicine. And so to talk about our descriptive statistics a little bit, we included almost 35 million Medicaid beneficiaries in our analytical sample, and about 68% of our sample had any primary care visit, but we split this out by having any primary care visit, regardless of whether it was in an FQHC or not, having a primary care visit at an FQHC, and then having a primary care visit at a non-FQHC. So about 61% of the sample had a visit at somewhere that was not an FQHC, and about 12.7% had a primary care visit at an FQHC. We kind of benchmark this number. If you look at some data from KFF in combination with the UDS data from HRSA, one of the benchmark proportions that we compare this to was that KFF has some work that estimates that about 16% of Medicaid beneficiaries visited or had services from FQHCs. And that 16% includes anything, any type of service at an FQHC, including very specific mental health types of services that may not fall into primary care definitions. And there were some other methodological details on why we may not exactly match that number, but our benchmark number was basically 16% at its max. And so we're estimating that about 12 to 13% of our sample had primary care visits at an FQHC. So our statistical approach was to sort beneficiaries into SVI deciles based off of their zip code level SVI score based on this data from Frenchy et al. And we calculated the distribution of Medicaid beneficiaries across these SVI deciles. And then we used a regression approach to calculate what we call adjusted access gaps by SVI deciles. And so we focused on three outcomes, the probability of having a primary care visit at all, the probability of having a primary care visit at a non-FQHC, and the probability of having a primary care visit at an FQHC. And then we also control for beneficiary level, age, sex, and diagnosis of chronic health conditions to help control for why primary care utilization would vary at the individual beneficiary level, and really focused on this main exposure variable, which were dummy variables for SVI deciles, where we omitted the first decile. And so essentially at each, we have 10 groups of vulnerability per the SVI. And in our regressions, we're estimating the difference between each of these deciles relative to the first decile, which is the least vulnerable group of beneficiaries based off of geography. And so these are our results from calculating the distribution of Medicaid beneficiaries across SVI deciles. And perhaps unsurprisingly, we estimated that over 50% of Medicaid beneficiaries live in the top 20% most socially vulnerable areas. And so the SVI is based off of percentiles, so there's an equal distribution among the nation, but Medicaid beneficiaries are disproportionately concentrated in the most socially vulnerable areas in the country. And these are what I would call our main results. This left graph is showing the results from the probability of having a primary care visit by deciles of the SVI relative to the first decile, which is the least socially vulnerable. And this 10th decile are beneficiaries living in the most socially vulnerable areas. And we did this through two different series. The blue line is showing the results for those including FQHC visits, and the pink line is showing the results for excluding the FQHC visits. And either way, whether you include FQHCs or not, we see this declining pattern where basically the probability of having a primary care visit decreases pretty greatly with increasing social vulnerability. But as you can see, when we include FQHC visits and primary care utilization, this blue line is a lot flatter and a lot less severe in terms of the decline of primary care access. And that is directly because when we estimated the probability of having a primary care visit at an FQHC in the same way, we find the exact opposite relationship. There is a pretty dramatic increase in the likelihood of having a primary care visit at an FQHC with social vulnerability. And so this isn't necessarily super surprising. We know that FQHCs are strategically locating in places that are underserved or already lack access to medical care. But this was a way to kind of quantify this in a pretty unique way to show exactly that the likelihood of increasing or the likelihood of receiving primary care services increases pretty substantially with social vulnerability at FQHCs. And so this gap between this blue and pink line here is what we thought was super, super interesting about the contribution of FQHCs and what we kind of refer to as bridging this access gap. FQHCs essentially reduce this disparity this disparity between the most socially vulnerable areas and the least socially vulnerable areas by over 50%. So if you imagine a world without FQHCs, that's what we were kind of estimating in the pink line here. And then once you add in FQHCs, this disparity between the most and least social vulnerable areas reduces by over 50%. And so the contribution of FQHCs into closing these access gaps is pretty large. To summarize the findings, the SBI explains part of the substantial geographic variation in primary care utilization and Medicaid. Highly vulnerable communities have much lower probabilities of having a primary care visit. But on the other side of that, FQHC utilization increases with the SBI or with social vulnerability. So the access gap between the most and least socially vulnerable areas without FQHCs is about 8.9 percentage points, but including FQHCs reduces that gap to about 4.7 percentage points. And then I didn't really go into a lot of detail, but in the paper we do some comparisons to basically show that the SBI identifies much more beneficiaries and a higher disparity than using a similar approach based off of simple income-based poverty rates alone. So this idea that I was referring to with Amartya Sen about identifying poverty or disadvantage in a multidimensional way definitely has pretty large implications for health policy. So what does this all mean? Before I get to our finding on FQHCs, it's pretty consistent with some of the other literature that has been published in this area. Pre-ACA, there was a study from Stacey McMorrow and Stephen Zuckerman that was discussing the role of federal funding at community health centers, and they found that this increased federal funding at CHCs basically slowed the decline in access for low-income adults, which is really, really consistent with our result here, is that FQHCs are doing a lot to help close these access gaps, although access gaps still persist within the Medicaid population. And all kinds of other policies have been studied as well with FQHCs. Medicaid expansion there's been work on how Medicaid expansion has been a pretty positive thing for improving access and care at FQHCs. But FQHCs also do all kinds of really cool things that we could also learn from, such as integrating organized delivery systems, can improve access to subspecialty care. FQHCs do a lot of great social risk screening and social risk, addressing social risk outside of non-medical factors. And some work from George Washington as well from a few years ago was talking about how staffing patterns, very diverse staffing patterns at CHCs can even help provide a lesson for other non-FQHC practices. So FQHC, our work on that FQHCs are doing a whole lot to close the access gap is definitely building on a lot of work that has come before this. And recently there was a paper from Kathleen Carey and Megan Cole that was looking at mental health access in CHCs and found substantial increases in mental health utilization at CHCs over the past several years, which is great on its own, but this translated also into about 16% fewer ED mental health care visits. And so although we don't, in our study, address specifically ED visits or hospitalizations, this idea that if FQHCs are improving access to primary care, that those effects are probably large and have indirect effects on other types of utilization as well. So before I get to the policy implications, like I was talking about the development of the CHC landscape that we have today started in 1965. And the CHC Chronicles from the Geiger-Gibson program really walks through the development of the policy support for FQHCs. In about the late 80s, early 90s is when FQHCs became what we call FQHCs in this designation. They were integrated into Medicaid and Medicare. In 2000, the year 2000 is when Medicaid and FQHC payments were kind of formalized through what's now called the prospective payment system that has helped establish a per visit payment to FQHCs to help establish some kind of sustainability in their operating model. And this was done with over 60% of support from Congress at the time under this administration. And then in the early 2000s, there was a huge expansion of funding for CHCs. Congress unanimously reauthorized the Health Center program and even authorized millions more dollars than George W. Bush was even requesting at the time. And then during the Obama administration in 2009, when the Obama Great Recession stimulus package passed, there was much more money also directed towards CDCs to help cover the cost of care for new patients that happened in a very supportive way. And then, of course, once the ACA was passed in 2010, the ACA provided $11 billion in increased CHC funding. So CHCs have had a lot of support since their founding from both sides of the political aisle, and that support has been pretty necessary to the growth of the overall CHC program. This is from a chart book from the National Association of Community Health Centers. In 1965, CHC served about 100,000 patients. Today, they serve over 32, close to 33 million patients. This ends in 2023, but today they are serving close to 33 million patients across the nation. And their patient population is incredibly diverse. About 37% of CHC patients are Hispanic or Latino, and about 48% identify as Black or African American. And Medicaid is a central role to CHC finances. About 50% of CHC revenue comes from Medicaid, which means the Medicaid program and CHC success are inextricably linked. CHCs serve a portion of patients that are uninsured, about 18% in 2023, but about half of their revenue comes directly from Medicaid. And so this access gap that we estimated in Medicaid is pretty insightful in the sense that FQHCs are doing a lot of great work to help close access gaps in Medicaid, and that likely it also extends to these other payer types as well. Although we just focus on Medicaid, which is the largest portion of revenue from CHCs. So the policy implications coming from this. We have geographic inequities. These persist even within the Medicaid population. So many of the discussions center on comparisons of Medicaid versus other types of payers, but we focus on very geographic variation within the Medicaid population. So this population is pretty homogeneous in terms of socioeconomic status by definition. To be eligible for Medicaid, there are income limits. But showing that geography continues to shape healthcare access beyond payer type is one of the important problems that we highlight in this. So in order to address these geographic inequities through policy, the idea is that we can use these small-scale multidimensional indexes to target resources, and we can do this in a variety of ways. We can do this through value-based payment models and provide bonus payments for providing care to certain areas. We can also implement workforce policies through the National Health Service Corps, loan repayment programs, or other types of incentive programs to basically incentivize providers and clinics to directly locate within these areas that are considered high social vulnerability. And the other big thing that's super obvious is just to simply expand the FQHC program. We can increase capacity at current FQHCs, increase the number and distribution of FQHCs across the country, and adequately provide support for the FQHC workforce. Just doing this on its own, as we know, FQHCs are already strategically locating in underserved and vulnerable areas, that just allowing them to continue doing that on a larger scale will likely have huge implications for closing access gaps to healthcare across the country. But FQHCs have challenges. There is a great report from the Commonwealth Fund that was published fairly recently discussing some of the challenges that FQHCs face. And they compared between 2018 and 2024. It was a survey that they sent out to CHCs. Almost all of these all of these categories about CHCs reporting workforce shortages on every type of workforce has increased. And so in 2018, for example, about 65% of FQHCs that they were reporting pretty large shortages in the number of primary care physicians, and that increased to about 70% in 2024. So this has always been a problem in FQHCs, and it seems to be getting the problem seems to continue to grow in terms of being able to recruit and retain an adequate workforce to staff these health clinics. One of the also the key reasons, like I said, Medicaid is an important part of the revenue stream, but one of the most important barriers to obtaining high quality care for Medicaid and particularly uninsured patients is the inability to connect them to specialists. Most FQHCs really just focus on primary care, but about 73% of FQHCs report severe difficulties on the ability to link their Medicaid patients to specialists, which means that Medicaid policy design directly affects the ability for FQHCs to deliver high quality results. So increasing access to specialty care, for example, for Medicaid would definitely assist FQHCs in improving patient outcomes. And especially now, in this kind of post-pandemic environment where telehealth has taken off in a pretty substantial way, about 94% of FQHCs say that the lack of patient access to broadband or technology is a substantial barrier or a large challenge to providing telehealth to patients at their community health centers. To kind of put that in perspective, many people talk about reimbursement and telehealth and reimbursement in general, but only about 67 to 75% of health centers say that low or no reimbursement for telehealth is a problem. And if you compare that to 94% of health centers relaying that the lack of patient access to broadband or technology is inhibiting access to care, kind of shows that the social determinants side of healthcare is preventing the telehealth from really being the most advantageous or being as advantageous as it could be into closing need gaps. And so one of the questions about these indexes is that why would we want to target areas rather than individuals? There's a paper from Michael McWilliams and team that was published in Healthcare that was discussing the concept of risk adjustment and payment allocations based off of individual and area level factors. And they were basically arguing that you could do both. But the idea is that if you have area level designations to incentivize providers and provide bonus payments or provide incentive programs, you would basically, that would be a more influential way on healthcare markets and network decisions that are made by healthcare plans or ACOs as they were in their discussion. But that you could still include individual level determinants in a risk adjustment strategy, but incorporating these area level definitions of areas with need gaps or areas that need healthcare resources is an important complement to that strategy as well. And there was a paper from Aubrey Limburg and team that was from out of Stanford that was recently just published in JAMA Health Forum that was looking at differences in various different social risk indexes in predicting health and mortality outcomes. And they compared different indexes, but they also compared the ability for the indexes to predict mortality and health outcomes compared to individual level social determinants of health, and found that area-based measures predicted health outcomes much better than individual socioeconomic measures. And we didn't necessarily do this in our data, but this has substantial implications for how we understand variation in health access and outcomes. The social determinants of health literature has done a great job of getting us to the conclusion that there's all these non-medical factors that affect healthcare access and health outcomes. But this idea that where you live and these concentration of these disadvantages it extends beyond your own situation, has important implications for how we target resources. So to conclude, we used zip code level social vulnerability to help explain geographic variation in primary care utilization and Medicaid, and found a very strong inverse relationship. And just to kind of highlight the innovation, some of what we did, like I said, we're using national database of Medicaid claims data from TAF When this research with TAF is in its infancy for sure. This is still a very new database that is difficult to work with, and quantifying primary care utilization, identifying FQHC utilization is one of the highly novel things that we did in this paper. And the primary care identification also came from actual provider activity, which means we were kind of innovative in how we identified what we counted as primary care and broadened this definition of what we would think of as primary care. And then we also, obviously the big things is we quantified the direct contribution of FQHCs to closing these access gaps. And so there are many opportunities to address these inequities. There is the SVI, there are other small scale geographic based indexes that could be incorporated in the policy for all types of incentives. That's kind of the first policy domain. But the second policy domain, of course, is to increase FQH support widely and not just increase the number of FQHCs, but increase the support for the FQHCs that exist now so that they can adequately address the challenges that they face in providing care for their patients. So I will stop there. You can check out our paper that we just published in JAMA Health Forum. Like I said, this was with a team at George Washington with Yoon Hong Park, Eric Lowe, Anushree Vachari, Cleese Erickson, and Patricia Pittman, that was partly supported by her. So.
Thank you, Jordan. That was a very rich presentation. I actually really kind of enjoyed your discussion at the end too, kind of really elaborating and fleshing out, some of the things you talked about. Start off the conversation. Could you expand a bit more on how you identified primary care providers in the claims data using this activity-based approach? And what are the policy implications for using identifying primary care providers based on care patterns rather than simply specialty? And one more follow-up. Did you, as part of the analysis, use specialty and see what happens? Did it impact the analysis at all when what have you?
Yeah. Yeah. So the conventional way that primary care is identified most in a lot of papers is by self-reported specialties or some kind of reported specialty. So primary care being family practice, general internal medicine, general pediatrics. Um, the challenge with the Medicaid data is that it's kind of difficult to identify provider specialties within the data. So you have to link the national provider identifiers, the NPIs on claims, to an external data source. And then you also have a pretty large problem about what to do with physician assistants and nurse practitioners, because they don't follow the specialty training and specialty kind of designation as physicians do. So grouping NPs and physician assistants into primary care is a little bit challenging. But the way that we approach that is that we use a combination of provider specialties with this activity-based approach. And basically, this activity-based approach identified providers that had a really broad clinical or concentration, or the lack of clinical concentration. So it was providers that were not just delivering cardiac services or mental health diagnoses. They had a very broad clinical practice, which means that the conventional approach doesn't mean a whole lot, in the sense that the conventional approach of identifying family practice and general internal medicine physicians, the vast majority of them ended up counting as primary care. But there was a small portion of specialists that we also included as primary care based off of their activity. And one of the most common specialties in that group was infectious disease. And so one of the great examples of that is there's a lot of clinics and practices that are specifically focused on HIV care. And instead of telling patients the people with HIV to go to various different clinics, is that infectious disease specialists often serve both as a HIV specialist and a primary care doctor. And that is true for many other complex chronic conditions, to where your specialist may also serve as your primary care doctor. And especially in Medicaid, where access is challenging, that once you have a doctor, that doctor may take on several different roles. And so we included a small portion of those specialists that met this definition of primary care activity in that. And for policy, that means that we have primary care payment rates and different policies for primary care, but what policy often considers primary care may be different than what we consider primary care conceptually or empirically in that approach. And then your question on whether it matters. It matters a whole lot from a workforce standpoint, but in terms of our main result about this disparity between the least and most socially vulnerable areas, really kind of however you do it, you still find this disparity between access to primary care. It's not driven by really this activity-based approach. It's really driven by a lack of to ambulatory office-based care in general. Um, and we still find this pretty large contribution of FQHCs to closing this access gap.
Okay, thank you, Jordan. Okay, next question. Can you elaborate a little bit more on the policy implications? That is, how should workforce initiatives, loan repayment, health professions regulation changes, et cetera, be targeted to areas with high SVI, high social vulnerability index, versus those with, or would these efforts differ from strategies in lower vulnerability areas? I mean, what's the impact here?
Yeah, that's a good question. The idea is, I guess the idea is not necessarily that different than the policies that we have in place now. We have loan repayment programs and the National Health Service Corps and different types of workforce programs that have incentives to so that providers and clinics locate in areas that are currently considered undersupplied or underserved. The problem, I think, with that approach is not necessarily that the policies are wrong. I think the policies are right. Policies probably actually need to be funded a whole lot more than they are. But this more narrow targeting of geography based off of zip codes or census tract or something that's much smaller than a county, I think is the first step because counties are pretty large. I mean, especially when you look at like Los Angeles County in California is like a massive. So there's a lot of variation within large counties that don't necessarily directly address communities that don't have access to healthcare. Um, but the second part of that is kind of identifying the within county variation, but identifying it based off of need, not just supply. So the kind of current approach right now is really just a supply side only analysis, and this approach about using the SVI targets smaller geographic areas, but it also kind of gets at this idea of trying to find areas that have gaps in access to care, not just the supply side.
Okay, thank you. And once more, you may use the Q&A panel to ask questions. And kind of follow up on this, you're looking at geographic areas, and you touched a little bit about this in your, conversation discussion at the end. Why not target individuals instead?
Um, yeah, I think so let me answer this first in this way first. This approach, not that the right way is always the easiest way, but we have a lot of data about geographic demographic concentration. I mean, this is the United States Census has been a huge wealth of data for decades, and we already have tons of data on all kinds of different geographic scales that help identify areas that have all these kinds of things that we care about in social determinants of health. The social determinants of health literature, a lot of the like really great groundbreaking or rich studies in that area have really rich patient level data, which the government doesn't always have on everybody. We don't have we have very little data in Medicaid claims data. Maybe in Medicaid enrollment data, states have a little bit more information based off of whatever kind of data they collect from beneficiaries at enrollment. But without this really highly specific individual level data, kind of the next best thing are these census level or area level metrics, which we can get from free public data. And so not that the easiest way is the right way, but one of the direct questions to that is that it would be really easy to do this, to target on small scale areas based off these concentrations of social determinants of health or multidimensional disadvantage. We can already do that pretty easily. But the more like conceptually, more direct question about if we should target areas rather than individuals, I don't think we're not saying that you shouldn't target individuals at all. We're saying that if you can identify these areas, that's a little bit easier policy solution to target certain markets. This paper from Michael McWilliams, I really like loved how they put this in the discussion section of their paper of talking about If you think about trying to incentivize provision in certain markets rather than certain people, that it makes it a little bit easier for providers and practices to kind of go after these incentives, providing care in certain areas rather than trying to track down certain individuals. Although you do get, once you get into these highly socially vulnerable areas, the idea is that you would get a larger proportion of people that have these individual social vulnerability metrics themselves as well. But of course, that leaves out that in these areas that don't come out looking highly concentrated in terms of social vulnerabilities, still have people with social vulnerabilities and social determinants of health that could affect their healthcare access that may not necessarily be targeted. And so that's why this Michael McWilliams paper was arguing for kind of the combination of both, which I think which is still a great policy solution. But kind of the approach that payers and value-based payment models have taken is in risk adjustment is making risk adjustment decisions and algorithms based off of individual social determinants of health, not necessarily based off of area measures. And so incorporating these area measures is still a huge value add on top of individual level metrics. And I guess I think personally I think both approaches they're complements, they should be used together. Although this paper out of this group at this other group at Stanford about testing area level metrics versus individual level metrics, part of what they found was that the area level metrics explained much larger variations in mortality and healthcare outcomes than individual social determinants of health, which is a pretty interesting conclusion to come to, because we kind of think about social determinants of health as like your own individual factors. But if what we're really saying is that where you live, it's more about where you live than your personal circumstances, then that has pretty substantial implications for how we address this through policy.
Okay, true. What about future applications of this research? Do you have any other plans, such as maybe apply it to behavioral health workers or something else?
Yeah, yeah, that's a great. So this could be replicated in all kinds of areas. Brianna Lombardi at the Behavioral Health Workforce Center at UNC, she and her team just published a paper that was similar, not using the SVI, but another index, looking at the location of behavioral health providers. And they kind of reached some similar conclusions that that behavioral health providers are not located in areas with high need or high disadvantage, and that there needs to be better targeting on different areas to try to connect patients with high need to the workforce. And I think the future applications, I mean, one of the things that that there's two kind of factors here. There's the issue of not having healthcare providers or healthcare resources directly located within those areas, which is what Lombardi et al.'s paper was about the locate practice locations of behavioral health clinicians versus the provision of care in those areas. And we're not necessarily in this paper, we looked at beneficiary level primary care utilization, not necessarily whether primary care providers were directly located within those areas. And so there's kind of this two-pronged policy solution where you can encourage people to locate within these underserved areas, but that doesn't necessarily mean that you have to uproot and relocate clinicians. Clinicians in certain areas can do a better job at outreach and expanding their Medicaid participation and different things to serve areas that have these access gaps.
Okay, okay. And question from the audience. Meg Simon would like to know, have there been any economic ROI simulations performed that could make the case for targeted investments used in SVIs? I hate to bring it down to only cost savings and dollar figures, but it comes
Uh,
down to that at times.
that
And your mic is going out. I know you mentioned you have that issue at times.
okay, I hope this is better.
That works.
Yeah, I that is a good question, Megan. I'm sure there have been. I'm not super aware of them at the time. But if there are, you should definitely drop them in the chat so we can to share them. I think the idea of putting this in the cost, the return on investment is super important. because I think we not money is not everything, of course, and a lot of the times in health equity, that's not necessarily the focus. I mean, equity is expensive sometimes. Ensuring access to care and improving health outcomes is not something that is not something that is cheap all the time. But a lot of people think that way. A lot of policymakers think that way. And so I think putting it in those terms of ROI and showing how, the idea of these bonus payments, like if you were to incorporate bonus payments and value-based payment models into, into incentives for providers to provide care in certain areas, I mean, the ROI could definitely be, improved outcomes, reduced unnecessary utilization. That this paper from Kathleen Carey and Megan Cole was kind of getting at this idea is that once you increase mental health utilization at FQHCs, you see like a 16 to 20% decline in ED use in that areas. And of course, this isn't ED use at FQHCs, this is ED use in general. And so increasing access in general has large effects on reducing kind of high cost um, care episodes. And so there is some return on that. But I think at this point, as far as I know, it's a little bit more going to have to kind of jump through some hoops to get to this return. It hasn't been calculated specifically in that kind of way to get to a number.
Okay, thank you, Jordan. And really, we're kind of right at the top of the hour, so we need to wrap things up. What's the takeaway here? If what should people take away? What's the big point?
I think I think the big point is not necessarily that different than what researchers have said over the past several decades. There's tremendous geographic variation in access to care and healthcare use. One of the things that I think is super important about what we show is that even when you look at Medicaid beneficiaries, the geographic variation in Medicare or in healthcare is not due to differences in concentrations of Medicaid enrollees versus private insurance versus Medicare. These geographic disparities exist even within the same population insured by the same public health program. And those disparities are kind of large considering that we estimate that they have to do with exactly where you live. So where you live basically it ends up shaping your access to healthcare, which has very important equity implications for how we deal with policy.
Hey, thank you, Jordan. That was very informative. I enjoyed it. I think the audience probably enjoyed it too. Um, so if that said, we'll go ahead and say goodbye. And well, I hope you enjoy the rest of your day, and I hope everyone in the audience has a good remainder of the afternoon. And of course, as usual, we hope to see you again in the future. Goodbye, everyone.